Please raise your hands if you are able to hear me. In the second group, you're all able to hear me?
Yes, sir.
Just raise your hand, that's it. Okay. So in the last class, we discussed about acid-base balance, and we saw that there are three systems involved in the maintenance of acid-base balance. And to understand anything about acid-base balance, you have to first know an equation called as Henderson-Hasselbalch's equation. Is that pH is equal to 6.1 plus log of bicarbonate by 0.03 into partial pressure of carbon dioxide. And so two things are going to determine the pH. One is the bicarbonate and other is the carbon dioxide partial pressure. And you have buffer systems and kidneys and lungs. So the order I changed is buffer systems, lungs, and kidneys. In that order, they are going to react to any changes in acid-base balances. And kidneys are playing a major role in acid-base balance. And they do this by three important mechanisms: by excreting hydrogen ions, by reabsorbing bicarbonate ions, and by forming new bicarbonate ions. A mixture of these three processes is going to help the kidneys in maintaining acid-base balance. And I also told you about the urinary buffer systems. And to make any sense about the processes, you should know that in the renal tubular cell, there is a luminal membrane and a basolateral membrane. And the transport proteins in the luminal membrane are different from the transport proteins in the basolateral membrane. That is what helps it to do this absorption, secretion, and all. Okay. Regulation of acid-base balance. Kidney regulation of hydrogen ion excretion and bicarbonate absorption. That one part I missed. So it is mainly increased H plus ions, increased PCO2, aldosterone, and body fluid volume changes, and EDH, which is going to regulate the secretion of hydrogen ions and bicarbonate in the kidney. In the second part of the session, or the day before yesterday, the second part we spoke about diuretics, very frequently used medicines in the clinical setting, especially the cardiology department and the nephrology department. Routinely, they'll be using diuretics. So, what is the use of a diuretic? Diuretics are mainly used to reduce the blood pressure and to decrease edema. Edema is accumulation of excess fluid in the interstitial spaces. And they are also used in the treatment of left ventricular failure where there is pulmonary edema. And that condition, this can be a life-saving drug medication, the diuretics. Diuretics basically act by inhibiting sodium reabsorption in different parts of the nephrons. So depending on their mechanism of action or their site of action, we can classify diuretics into six groups. So osmotic diuretics, then thiazide diuretics, then loop diuretics, then ADH inhibitors, and aldosterone antagonists, and one more sodium channel blockers in different parts of the nephrons. And before all this, you should tell what is a diuretic. It's a substance which increases the urine volume. Okay. So in this session, I've just put the questions in the screen share, and you can ask me anything that you want. Or I'll go one by one. You can just unmute yourself and ask me any doubt, or I'll go one by one question. Shall I go question one by one? Raise your hand if you are okay with that.
Yeah.
Okay. So the first question, essay question here is explain the steps of urine formation. the current syllabus curriculum changes for you, this type of questions are unlikely to be asked. Okay, but anyway, urine formation involves a combination of three steps. One is the glomerular filtration, second one is the tubular reabsorption, and the third step is the tubular secretion. So, filtration is the first step. It happens at the level of the glomerular capillaries. And in the process of filtration, a lot of plasma is being filtered. I told you when I spoke about acid-base balance, a lot of plasma is being filtered and reabsorbed. This helps in the precise regulation of the ECF volume and osmolality. So there you have to tell about the definition of GFR, amount of filtrate formed by all the nephrons of both the kidneys in 1 minute. What is the value in males? What is the value in females? It is different. And then you have to tell the factors regulating GFR. So these factors regulating GFR, you can approach it in different ways. Different books will approach it in different ways. Some books will say renal blood flow is the most important factor which is going to determine GFR. All factors which are going to regulate renal blood flow in turn is going to determine the GFR. That is one way you can approach your answer. The second way you can approach your answer is little bit if you want to go to the depth. You will talk about the Starling's forces which are acting across the capillaries, glomerular capillary membrane. There is a membrane here called as filtration membrane. So just like in the lungs, you have a membrane. What is a membrane in the lungs called as that special membrane? The special membrane in the lung is called as respiratory membrane. Okay, so like that you have a membrane in the kidney which is called as filtration membrane. So this filtration membrane is membrane across which glomerular filtration takes place. So there is a special structure here. You have to look up, you have to draw a diagram of the filtration membrane when you're talking about the GFR. And you'll talk about the glomerular capillary hydrostatic pressure, glomerular colloidal osmotic pressure, interstitial fluid or Bowman's capsule. Here it is Bowman's capsule hydrostatic pressure and Bowman's capsule colloidal osmotic. Bowman's capsule colloidal osmotic pressure is zero. And for one important reason, the glomerular capillary hydrostatic pressure is very high. Compared to the hydrostatic pressure in the other capillaries, the glomerular capillary hydrostatic pressure is very high. What is the reason for that? Why is the glomerular capillary hydrostatic pressure very high in the kidneys, whereas in the lungs it is very less? In other places it is around different values. Any reason for that? I had explained in the class.
Afferent arterial diameter is very big.
Who is this one?
Supraja sir.
Huh? Supraja.
Supraja sir.
Tell me, what is the answer you got?
Afferent arterial diameter is very high, more than efferent arterial.
Afferent arteriole is short and broad. Efferent arteriole is narrow and straight, long. Okay, so efferent arteriole offers more resistance to outflow. So blood is flowing into the glomerular capillaries, but it cannot go out. That is why glomerular hydrostatic pressure is high. So all factors which determine glomerular capillary hydrostatic pressure are going to determine GFR in a normal person. That is one way you can approach the answer. And in the factors which influence the glomerular capillary hydrostatic pressure, you will tell about resistance of afferent arteriole, resistance of efferent arteriole, renal blood flow, and so on. Okay. So then you will talk about tubular reabsorption. It's very simple here. Tubular reabsorption is all substances which are needed by the body, like glucose and the other electrolytes, which the body cannot afford to lose, are going to be reabsorbed, almost 10%. Okay, and then the substances which are not needed from the body, apart from filtration, they are also going to be excreted. So I'll try one more screen share here. One second. Oh God, what happened here? You leave it. Okay, so there is a diagram in Guyton where it shows the different permutations and combinations of filtration, reabsorption, and secretion. That part you can see. And wherever there is reabsorption or secretion, which ion is involved? In 99.9% of reabsorption and secretion, one ion is there. Either along with ion, in that ion, the substances are reabsorbed, or in exchange for that ion, substances are secreted. What is that ion? Sodium. Sodium. Okay.
Sodium.
So please go back and look up the transport mechanism across the cell membrane to make up any sense about this. Okay. So define. I'll go to the next question. Define GFR and give its normal values. So I already told you GFR is defined as the amount of filtrate which is found by all the nephrons of both the kidneys in 1 minute. The factors affecting a normal value is 125 ml per minute in males, and it is around 110 to 115 ml per minute in females. The factors regulating GFR. Just now I told you. You can say renal blood flow, factors affecting renal blood flow. But a better way of telling your answer will be you will tell about the hydrostatic pressures, and that you will take it from there. Okay, so you'll tell the Starling's forces across the glomerular capillaries. Then you'll tell hydrostatic pressure is the most important one, and all factors influencing the hydrostatic pressure. So there you'll get many points to write. So factors which influence the resistance of the efferent arteriole, like sympathetic discharge, circulating hormones like ADH, angiotensin 2, aldosterone, epinephrine, norepinephrine, and so on. So many things are there. Tubuloglomerular feedback is also one thing there. Renin, angiotensin, aldosterone. At some point in your discussion, you can bring it. Okay. Measurement of GFR, you can do direct measurement by flow stop start techniques, micropipette insertion, or you have indirect methods, the concept of clearance. And there is one formula which they use in the lab. GFR is equal to U into V by P. That formula is there. Apart from that, there is one more correction they do for the height and weight. Please look up the in the net or somewhere that formula and tell me tomorrow. Okay. So when they want to measure GFR, one substance which you can use is inulin, not insulin. Insulin, if you give IV, patient will die because of hypoglycemia. It is inulin, INULIN. So again, here you have to tell what are the criteria you use for a substance to use it for measuring GFR. So it should be non-toxic, it should be freely filterable as freely as water, it should not have any influence of its own on GFR, it should be easily available, it should be cheap, its concentration should be measured, it should be freely filtered, it should neither be reabsorbed nor secreted. So those points are there. So inulin is one substance which meets all these points. Problem when you use inulin is you have to give a continuous intravenous infusion to maintain the plasma level of inulin concentration constant. So to overcome this, they use one substance called as creatinine. So creatinine clearance is what is used in the lab. So they measure the urinary creatinine clearance, plasma creatinine clearance, and that by that they are going to do the measurement of GFR. And role of kidneys in maintenance of acid-base balance. So this I have been telling you for the past 2-3 days again and again and again. So you'll tell what is a normal pH, why we express hydrogen ion concentration as pH. You'll start your answer with the Henderson-Hasselbalch equation, and you'll tell bicarbonate and PCO2 are two factors which are going to measure, determine this thing. And you'll tell a little bit briefly about the buffers because it is 15 marks. Little bit about the buffers and lungs and their role in 2-3 lines you'll finish off. Then you'll start with the main thing about the kidneys. So those three mechanisms: secretion of hydrogen ions, reabsorption of bicarbonate, and formation of new bicarbonate ions. And in the process of formation of new bicarbonate, you will tell about the buffer systems, the phosphate buffer system and ammonium ion buffer system. And then mechanism of formation of a concentrated urine. You have to give a introduction, is it not? So when kidneys are having this amazing property of forming a large volume of dilute urine or a small volume of concentrated urine, so kidneys can secrete solutes independent of the water. If they want, they can secrete only solutes, no need of secreting water, or they can secrete only water, no need of secreting solutes along with that. So this independently they can manage the solute and salt, the water and salt, solvent and solute. So that is what helps the kidneys to form a concentrated urine. So here you will tell two criteria are needed for formation of a concentrated urine. One is ADH. The second one is the presence of a hyperosmotic medullary interstitial fluid gradient. So why that gradient must be there? That gradient is providing an osmotic gradient for water to be reabsorbed. Only way water is reabsorbed is by osmosis. And for osmosis to take place, an osmotic gradient should be there. And that is established by the countercurrent mechanism. Two are there. Countercurrent multiplier where it is operating, countercurrent exchanger where it is operating. And what is a countercurrent system? Where inflow, outflow parallel to each other, opposite to each other, and close to each other. And the special features in the loop of Henle, which help it to function as a countercurrent multiplier system. Those 7 hypothetical steps. And you should not forget to write about ADH. ADH, its mechanism of action. And then you have to write a little bit applied aspects here. If ADH is not there, what is going to happen? And if there is some problem in the nephron, it is not that 1 sodium, 1 potassium, 2 chloride exchanger. If it is not there, what is going to happen? If it's not functioning properly, and diuretics also issue. That will complete your answer. This fifth question is something which needs a bit of common sense. Yeah. So the role of kidneys in maintaining ECF volume and osmolarity. Who will tell me how osmolarity is maintained? Who will tell me how the ECF osmolarity is maintained? I've been telling that again and again and again throughout. I've been telling. Anybody can unmute themselves and tell me that.
By the 3 systems: blood buffer systems, lungs, and the kidneys.
Sirisha, think. I'm not asking acid-base balance. I'm asking osmolarity. Anybody? How is the ECF osmolarity maintained?
Maintaining sodium concentration.
Huh?
Sodium concentration.
Ruhi, na?
Yes, sir.
Huh? I did so much explanation when I talk. There's somebody here. It is so vague. Feedback mechanism ante enta vague ga undi kada. When I spoke about how osmolarity is maintained, I told you can add water or remove water, and that will help to maintain osmolarity. Which hormone helps to add water and remove water? ADH.
ADH.
You are not understood urine concentration. I think still you all have to read again. Okay, ADH helps to maintain osmolarity. Okay, if it is hyperosmolar, water is added. If it is hypoosmolar, water is removed. So ADH helps to maintain osmolarity. Yeah, tell me, Ruhi.
Can't it be sodium concentration? Because that is more abundant in the extracellular fluid. in the guideline it was written that sodium concentration helps to maintain.
I'm coming to that. I'm coming to that part. Okay. ECF volume is maintained by sodium. Wherever sodium goes, water is reabsorbed. So sodium, aldosterone via sodium helps to maintain ECF volume. ADH via water helps to maintain osmolarity. This is the concept you need to have. And that is what is happening in a normal person. At some point of time, these two systems are going to overlap. Okay, so if you look at the factors which stimulate ADH secretion, it is not volume changes which comes first. It is changes in osmolarity which comes first. When the ECF volume becomes hyperosmolar, ADH is secreted, water is added, it gets diluted, it comes to normal. When the ECF volume becomes hypoosmolar, ADH secretion stops, kidneys stop reabsorbing water, water is excreted, water is removed, it becomes hyperosmolar and comes back to normal. So please go back and look up this concept. At some point, these two are going to cross. There is going to be a crosstalk between the aldosterone, sodium, ECF volume, ADH, osmolarity, water, and that is it is going to. But day-to-day operation, osmolarity is maintained by ADH, and ECF volume is maintained by aldosterone via sodium. This is the concept you need to have. So please read up this. Wantonly, I kept that question. Okay, there is a separate chapter in Guyton. There is a separate chapter very nicely in Guyton and Genong also. They are given role of kidneys in the maintenance of ECF volume and osmolarity. So please read up that. What are the functions of kidney? Who will tell me?
Maintenance of water and electrolyte balance.
Who is this?
Ramya Teja, sir.
Okay, then any other answer?
Regulation of blood pressure, pH, osmolarity.
అది కాదండి किडनीज नी ये सिस्टम लो चदिवारू कौन से सिस्टम ने पढ़ा आपने किडनीज को उस सिस्टम को क्या कहते हैं
Excretory system.
So first function ఏం చెప్పాలా మీరు
Formation of urine.
Formation of urine. Why it is forming urine?
To excrete waste products, metabolic waste.
First function of kidney is excretion of metabolic waste products. Excretion of metabolic waste products like urea, uric acid, ammonia. So many waste products are there. Okay, so that is the first function of the kidney. Yeah, cheppesam kada. So excretion of metabolic waste products, first function. Next, maintenance of ECF volume and osmolarity. Next function. Already me kallu mundu panchapandavulo enta maintenance of acid base balance. Maintenance of acid base balance. Then any other function? Endocrine
hormonal
function. Endocrine function. What is that endocrine function? Renin, then
erythropoietin,
then prostaglandins. Okay, then the same thing, if you want little more little bit, if you are clever, you'll tell hemopoietic function. To add one more point, it helps in production of RBCs by secreting erythropoietin. Then any other function of the kidney? Vitamin D3 is another hormone, it is secreting itself in the activation. Any other function? Hormonal ayindi, erythropoietic ayindi, excretory ayindi, ECF volume and osmolarity ayindi, acid base balance ayindi. Regulation of blood pressure plays a very important role in the regulation of blood pressure, is it not? And then it is also going to help in some little bit of glycogenolysis also takes place in the kidneys. Okay. Now, if you remember this, if a person is having chronic kidney disease, end stage kidney disease means both kidneys have damaged. irreversibly, acute or chronic kidney damage. Both kidneys are gone beyond the point, right? So what will be the problem in this person? What all problems he will face? He will not be able to excrete the metabolic waste products. All those metabolic products are going to accumulate, especially urea. Urea concentration will increase. What is that increase in urea concentration called as uremia? Uremia. Some accumulation of all the metabolic waste products. ECF volume and osmolarity will not be maintained. So there will be edema. Okay. Then the erythropoietin will not be secreted. So there will be anemia, long-standing, especially acute. So long-standing patient with long-standing kidney disease, he will have anemia. He will have vitamin D deficiency. He will have acid-base imbalances. His blood pressure will be high. Kidneys are playing a very important role in the maintenance of blood pressure. His blood pressure will be high. Okay. So if you want to treat a patient with chronic kidney disease, you have to give him a new kidney, or you have to give him dialysis. And in this process, in between, you have to keep giving him vitamin D supplements. You have to give him erythropoietin injections. You have to maintain his acid-base balance. Carefully, you have to maintain the fluid input and output. Okay. So in the short notes, anything you want to ask me? In the short notes. First, I'll focus the first 9. This juxtaglomerular apparatus can also be asked as renin-angiotensin-aldosterone system. Very important system. I had discussed this in the class, I remember. The renals play. What is glomerular-tubular balance? Somebody had called me on that.
Reabsorption rate in the tubule is increased in accordance with the increased tubular load. So reabsorption rate in the tubules is increased as the tubular load is increased.
Here somebody told constant something here and there. Correct. Who is this? Who is this? Huh? A constant percentage of the GFR is reabsorbed in the proximal convoluted tubule. 65% of whatever is filtered is reabsorbed in the proximal convoluted tubule. And this is possible by the glomerular tubular balance. It is possible because of the changes in the physical forces which are happening in the peritubular capillaries. The same, what is that, hydrostatic pressure and other things, same thing. That is the one which is helping in the reabsorption. Please look up that. And what is the role of urea in countercurrent multiplier? Urea recirculation helps in the medullary fluid interstitial gradient. Urea recirculation. That part you should not forget. What is a cystometrogram?
Graph measures the intravascular pressure as the volume increases.
Pressure volume changes inside the urinary bladder. A graph which shows the pressure volume changes inside the urinary bladder. Very frequently asked question. Cystometrogram. Innervation of urinary bladder. Micturition reflex. Very, very, very frequently asked questions. Renal function test. Viva. Viva they'll ask you. Okay. So any other chapter you have, any doubts you can ask me. Tomorrow I'll start with blood pressure. Please read about blood pressure. Please read up about the blood pressure, okay? The definitions, the normal values, and what are the factors determining blood pressure and factors regulating blood pressure. Please read up. Okay. Anything else you want to ask me, or we'll stop this session? 12 o'clock, Arpana will start with the splanchnic circulation. Today's class, the take-home homework for you is explain the role of kidneys in the maintenance of ECF volume and osmolarity. ADH is osmolarity and aldosterone is volume. Just read up about that, you'll understand. Maybe we can discuss. Tell me, Ruhi.
So about the hormones ADH, angiotensin II, and aldosterone, they all have the same function of sodium reabsorption.
ADH? What are the three?
Aldosterone and angiotensin.
ADH is mainly having action of reabsorption of water now. Quickly it will act to reabsorb water. Any changes in ECF or osmolarity have to be corrected very quickly. And that is done by quickly adding or reabsorbing water. You read the chapter, we'll discuss. I don't think you read the chapter. You read the chapter, we'll discuss.
It was written that it helps in sodium reabsorption also.
Which one?
Ditin.
No, which hormone?
Angiotensin II.
Yeah, angiotensin II and aldosterone are helping in reabsorption of sodium. Not ADH. Angiotensin II helps in GFR changes by acting on the afferent and efferent arterioles, vasoconstriction. That part you have to read.